Namaskar. I am Ravi Gupta. I am editor-in-chief of a magazine called eHealth and CEO of Elets Technomedia. I welcome you all to this session on digitization and changing dynamics of public health. And we are organizing this session as a part of the Digital Health Conclave, which is being organized by Elets in the collaboration with AWS, Amazon Web Services. And we are joined by an eminent set of speakers today. We have Shri Mohammad Safirullah, who is the Additional Secretary, Electronics and IT, and Project Director of eHealth Kerala. Welcome, Safirullah ji. Thanks for joining us in this session. Namaskar. Uh, we are joined by Dr. Hira Lal, who is the Additional Mission Director, National Health Mission, Government of Uttar Pradesh. Hira ji, namaskar. Thanks for joining us. And we have with us Mr. Sridhar Gadi, who is the founder and executive chairman of Contela. Sridhar, welcome and thank you for joining the session. And we have with us Aditi Oberoi, who is a product manager, beneficiary management, identity management, and national portability NHA, National Health Authority. Welcome, Aditi. Thanks for joining us.
Thank you.
Namaskar. Thank you. So, while we have the NDHM are being announced by the government, which is a National Digital Health Mission, which is a revolutionary step, which has got taken by the government for introducing IT and health in a big way. And in the morning, we had a presentation by Shri Abhishek Singh, who is the CEO of NEGD, National E-Governance Division, Ministry of IT, the Government of India. He spoke about IT and health vision of the government, and also we had the Director General of NIC, who spoke about the various aspects of health IT, and also we had Shri Kiran, who is the advisor technology in the National Health Authority, Government of India, speak about the health stack and the various aspects of it. And in this context, our next our this session is about digitization and changing dynamics of public health. So we have with us a case study of Kerala, where the a lot of initiatives are happened in IT and health. So let me request Mr. Safirullah or Mohammed Safirullah to give his presentation to start with this in this session. Safirullah ji, over to you.
Good afternoon, eminent members of the panel and the audience. I'd like to thank Elets and eHealth for giving us the opportunity to present this particular project. For the next 15 minutes, I would like to identify the salient features of eHealth project in Kerala, where we attempt to create one EMR for every citizen. And in the last 5 years, what has been the progress and what is the way ahead that we are trying to do in the context of a lot of innovations which are happening across our country. eHealth project envisages to create an electronic health record system, integrate with the public health management system. One of the primary difference or the uniqueness of eHealth Kerala project is that it not only attempts to target the hospital management system, but also integrates with the public health management system. What we mean by public health management system is the activities which happen at the household, like the immunization, the various health aspects, the monitoring of diseases, and all these things would together constitute a public health management system and integrate with the hospital management system. So there is an integrated health record across the board for every citizen. We started this project in the year 2016, primarily with the funding from Ministry of Electronics IT, then called as Department of Electronics and IT, Government of India, and with the contribution from Government of Kerala, contribution from both the central and state governments. and we attempted to move towards creation of a comprehensive health database system, integrating four major aspects: the demographic aspects, the socio-economic aspects, the public health aspects, and the medical data. In short, the e-health project, we attempt to create an electronic health records, medical records, uh, by the following. That is, by creating a centralized hospital management system, a centralized public health management system, by integrating the disease surveillance system, also by integrating through various technical means with various programs of Government of India, Department of Health. We are trying to link with the PACS and the other archival and communication system, uh, and broad-based the telemedicine, which is already there. In addition to that, we are also looking at the administrative model at the various levels of hospitals, from the medical college to the family health centers and the primary health centers, and also the integration with other sister departments of health. Before I proceed, I would like to point out the concept of family health centers, where Government of Kerala is attempting to convert the erstwhile primary health centers into FSCs. An FSC is differentiated by a patient-friendly OP system, when integrated e-delivery system, by 24 cross 7 services, provision of labs wherever possible. The idea of Government of Kerala is to make sure and upgrade the FSCs, that is the family health centers, so that most of the aspects at the community level are taken care by the FSCs itself. Uh, in a e-health project, the infrastructure that we are trying to do is at the data center, a separate architecture is done for e-health project with a DR recovery provision. We are trying to link all the hospitals at all the levels with two connections, which is the primary and secondary. In that context, I would like to also point out the ambitious Kerala fiber optic network, which Government of Kerala is working on, where we attempt to connect each and every government offices, which includes education institutions and hospitals, through an optic fiber link. The project is in nearing its commissioning stage. A lean server is provided at each of the hospitals, because we have to handle the connectivity downtimes, and almost a real-time data access should be there, because this is a critical area that we are dealing with. A LAN and hardware ecosystem in each institution, and the UPS and diesel generator. These are the infrastructure provisions. In the integrated hospital management system, primarily depends on a unique ID for the patients across the state. This is Aadhaar linked, and with an Aadhaar, there is a unique ID which is system generated for each of the patient. So if a patient, let us say, if an individual walks into a family health center, takes an advice at the PHC center, and tomorrow he or she goes to the community health center, or at the district hospitals, general hospitals, or the medical colleges, there is an integrated record which is available across all the levels. There is a queue management system which has been scientifically designed, and it is operational at about 160 institutions. Share the data later on. And as the data is highly sensitive, we ensure high level of confidentiality. The technology architecture is something like this. There is a citizen, which is who's the center of the entire system, who can access the hospital services through any of the online means, apart from the web portal, the mobile, the kiosk, and these are the means at which the hospitals, the delivery of services is given. And we talk this system is integrated with the cloud architecture, which I talked about. We also have an integration with the lab equipments at these hospitals. We have integrated a few public health labs where these electronic laboratory, the outputs, these are integrated dynamically. So what happens is that once the report is generated, it is pushed to the servers. And as of now, we don't give the soft copies, but all the records are aligned along with the EHR. Then at the DB level, we have the DB servers and the SAN storage. We are in the process of establishing a LAN connectivity in about 1,300 hospitals in Kerala with a redundant connection. The centralized hospital management system which includes 25 major modules and 31 specialty modules. This major modules are like reception, queue management, pre-checkup, nursing, consulting, consultation room, pharmacy, lab bills, and other stuff, including packs and blood bank. We have recently started telemedicine also, which has been widely used during the COVID times. The specialty modules at this stage, we have not launched any specialty module because each specialty module is an ocean in itself, and we'll be integrating it over a period of time. The idea right now is to expand it to the family health centers and the CHCs. The major features, apart from mapping the entire hospital workflow and maintaining the confidentiality, is that there is a GIS-based digital public health survey, which helps us in tracking the diseases surveillance at a later stage. There is a tablet for public health staff who have mapped the almost 75% of the state population, and the inbuilt mechanism for business continuity and seamless integration with national programs. Uh, the records that we generate are compatible with international standards like SLOMIT City and Leone. Uh, we have the queue management system, which has been highly successful. I'll show you a few snaps later on during this presentation, and even online registration of patients, including UHID and appointment generation. There is a real-time data capture at the point of service where the patient history is viewable for the doctors. The screens have been designed and redesigned many times so that it is patient and user-friendly with the doctors with basic minimum keyboard movement where the doctor can store his or her preferred list. A template can be customized. At the pharmacy, it is customizable, and we can also monitor the data at the back end to see to what extent certain things like antibiotics or other stuff are given. Because once the data is there, it is up to us to do all this analytics. The list of their drugs and test results are updated in the patient record once the service is delivered. Talking about the handheld devices, we have distributed, as I was mentioning, the public health module. We have the data surveyed and taken about 2.5 crore data of the citizens. About the population of Kerala is about 3.4 crores. At the village level, we have the data of the public institutions, education institutions, other utility shops, establishment, other demographic data at the house level, and at the family level, we have the name of and the date of birth, age, gender, and blood group, and other materials, other data at the family level. This digital family health register is is a union of a health database for the state and a unique identification for the entire individual. These are the features which are there, but right now only a few features like birth registration, death migration registration, and other certain features are there in the PH module. I'll explain a bit later. We have not gone to the next higher level. This is a snapshot of the dashboard that we monitor. There are about 1,300 hospitals, to be specific, 1,278 hospitals, which includes medical colleges till the family health centers. And as we speak today, it is functional in 100. eHealth is functional in 160 hospitals, and implementation is progressing in its the second half of implementation progressing in 330 more centers. So we plan to hit across 450 hospitals at the end of this financial year, that is in the next 3.5 months. This is the date of commissioning. This is there in the public site. You can see it later. The 160 that I'm talking about is, we have about, as you can see on the left-hand side of the screen, we have 139 family health centers, as we call it, or the PHCs, as the general term is. 236 more are in its implementation stage, which are planned to be commissioned before March this financial year. Then we have the community health centers, taluk hospitals, district and general hospitals, medical colleges. Currently, we have it running in 8 medical colleges, though it is not full-fledged. But yes, we do have it OP running at all the medical colleges here. And other, when I mean other, I refer to cancer hospitals and public health labs. So we have about 160 institutions where eHealth is functional right now, and about 281 where the implementation is in progress. On the right side of the screen is a splitter across the districts, and you can find out most of the implementation right now is centered around Trivandrum, which is the state capital. We started rolling it out in the state capital because we want, because it's a very sensitive system. We didn't want it to fail initially. It had to be hand-holded, and we launched as a pilot basis in Trivandrum Medical College. Uh, we have procured and distributed 9,500 tabs where a survey was done in the last 3 to 4 years. And I'm happy to say that about 79% of the residents of Kerala have been surveyed. The house survey records are about 68 lakhs. We have about 72, 73 lakhs households in the state. The citizen survey is about 2.5 crores. As I said earlier, the population of Kerala is about 3.4 crores. So this is the data which is right now there. It's the inauguration by Honorable CM, the distribution of tablet, Honorable Health Minister inaugurating the telemedicine recently. These are some of the photos I like to talk about the transformation. This the photo at the top is Trivandrum Medical College is one of the very what do we say, the high-end hospitals in the state. It's has a footfall of more than 5,000 every day. This is one such photo where it was taken before and after, where along with the Ardham project, where that is Ardham is a priority project of Government of Kerala. It is about transformation of hospitals. The entire OP was transformed. The top ones, as we see, is the hospital before, and the photo at the bottom is after. This is one photo in the Kasaragod district about how the integration is done. We have this is one OP division where the nurse screens the patient and takes the basic vitals of the individual, and then the doctor does a second level screening. We are now going for the next quality certification, and 14 hospitals or more have been awarded the highest quality certification by NHM. Some of the accolades here. So I would like to conclude. I have been given 15 minutes. I'd like to conclude by pointing out the vision of eHealth once again. We are in the process of establishing the family, the electronic health records for the entire population. We hope to cross about 450 hospitals before the end of this financial year, and then move on to the specialized versions later on. I would have to admit that the progress has not been as smooth as we envisaged. Initially, we started thinking that we will be finishing off the project in 3 years, but in last 5 years we have been able to achieve roughly 30% of the target because it's a highly complex system, and the system has gone on repetitive chain at least for 4-5 times in the way that we developed OP and specialty modules, 4-5 modules that we developed, like for gynec, ophthalmology, the ortho. These are all highly specialized modules. Then at the specialized level, at the doctors committee, then we come with a lot of recommendations, and again it comes back. So it has been a very mixed, what do we say, experience for us. But however, I would like to say that the government is committed and we are moving forward. And I hope in a year or so we'll be moving vastly ahead on this. Thank you for the opportunity.
Thank you, Safarullah ji, and thanks for highlighting in detail about the e-health project implementation in Kerala, and thanks also for highlighting the challenges. As you mentioned that the project has been delayed, and you also talked about how much back and forth one has to go between the medical fraternity specialists in the hospitals uh, and back in the system. So, as we are like all are aware, it's like healthcare IT is a complex subject, and but it is the need of the hour. And let me welcome our speaker, Mr. Raghavendra from Step One, who has joined us. Welcome, Raghavendra. Thanks for joining. So let me straight away get into the session. And first, question which I will like discuss with the panelists. that how digitization in healthcare has changed during and after COVID-19. And
Dr. Ravi, if you don't mind, I have a question for
yeah, yeah,
which,
sure, sure.
yeah.
Okay,
So
Aditi,
can I ask now or I can
I
ask
think if you
later?
like asking a bit later, it will be good. Is that
Sure,
okay,
sure.
Aditi? So yeah, yeah. So
Perfect, perfect.
we have a half an hour for a Q&A in the end, and we will like do that. So should be okay. So let me request our panelists to give your comments on how is like digitization in healthcare has changed during and after COVID-19. So let me request Sridhar Gadi to lead the discussion, and each panelist I will like request that if everyone can speak for around 5 minutes so that we can discuss more points. Sridhar, over to you, please.
So good evening, everyone. So before COVID, we as Quantilla built a smart city platform. Most of the cities all over the world use our platform. As part of smart city mission, there are several verticals. It could be parking, waste, lighting, safety, security. Public health was never focus as a use case. So when this COVID happened, immediately we have put together a technology platform leveraging the CCC command control platform to fight COVID. So during and later, what are the challenges and how the city or the countries overcome? First of all, to fight COVID, you need to integrate different departments. It could be police department who are setting up containment zones, or uh, uh, it could be public health department who has lots of information. It could be hospitals who are providing actual beds and infrastructure. It could be quarantine centers. It could be disaster management group. The first thing is integration of different departments into a single platform, so that the city officials or the government officials can take the holistic view of the entire situation and take the decision, and the data flow happens between all the departments instead of in silos. Second, once you have all this data, which becomes easy to predict where the next COVID situation would be, or how the healthcare system will affect. For example, is this hospitals enough in this area based on the prediction of how many cases would come in next month or two? So the prediction, it would be very helpful. Third, not only integrating different department into a single platform for the holistic view, so there are most of the cities also developed field responder app as well as citizen app. So field responder app is for the healthcare workers wherever they are to enter the data into the system so that it's integrated at field level, and citizens to consume the data and get the service to fight the COVID. Thank you.
Thank you, Sridhar. That as you highlighted this, that as you were developing this smart city platform, the health was not a priority earlier, but after this COVID has happened, it has become a top priority of this uh, 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 each city and each state. Let me request Aditi Oberoi to talk about how do you see this digitization of health happening in the COVID times, how it has changed and evolved. Aditi, over to you. You are on mute. Yeah,
I'm sorry, Ravi.
yeah.
I lost
Okay,
I lost you in
okay,
the middle.
okay.
It was I couldn't
It's
hear
okay.
your
It's okay.
question.
So I will
Yeah.
just like repeat the question, which is how has digitization of health,
Sure.
public health, has changed in this COVID times? Like our perception about digitization of health earlier, before COVID and post COVID, how it has evolved. Aditi, over to you.
Okay, sure. So I feel it has changed. I mean, magnanimously, and it has gone multifold to a different level. If I take National Health Authority as an example, or it's not that our country did not invest into healthcare or digitization of healthcare prior to COVID happening. So we already had schemes like Ayushman Bharat running for the last 2 years before COVID happened. But yes, definitely, uh, platforms for telemedicine came into being. Then integration with the already existing healthcare platforms that were already available in the public domain came into utilization with the COVID-19. So what I feel is a personal opinion of mine, which I feel happened during COVID, is that there were not just efforts made around digital transformation during COVID, but efforts were also made around non-digital transformations, because there are certain challenges wherein our country like India, which has multiple different terrains and different reaches and different sorts of infrastructure, and the governing agencies are different. In those sort of scenarios, only digitization may not solve your problem, but also making sure that the non-digital solutions are also well complemented. So I saw a few examples of how that is being done. Like there are some initiatives, if I may name. So there is this entrepreneur venture called Khushi Baby, which uh, which is based out of Rajasthan, and they make sure that they collect pregnant ladies and her child's immunization healthcare records in a chip in a pendant. And that is done on an offline manner, and when the lady goes and to her healthcare provider, the chip is read and the entire data is then made electronic. So I think it is a combination of digital as well as non-digital efforts that came into being after COVID-19 on the whole. But if you see in terms of how the governments have been functioning, I think it was always a key criteria to make sure that healthcare works in a digitized manner, is what my opinion is around this.
Sure, Aditi. Thanks for your inputs, and let me request Dr. Hira Lal, who is the additional MD of NHM in the government of UP, to talk about your view about the digitization of public health challenges after COVID.
Okay, thank you. I was listening Kerala. Actually, health services is quite different from Kerala to UP. I am in UP. Kerala is more illiterate as compared to UP. Kerala is too small as compared to UP. So the healthcare services before COVID and after COVID. One thing I have observed, there is a patient on one side and the health service provider, our doctors, our infrastructure, our nurses and all the staff is on other side. So during COVID, all the health services came at standstill all of a sudden due to pandemic, and we had to supply our services. So there was, and we along with following all the norms, masking, distancing and all that, so only solution was the technology. So covid had practiced COVID had forced us to practice and adopt how to use digital health services. So it accelerated the adoption of digital health care services on both the parts, patient as well as our health care service providers. And the best part is that the adoption of digital health care services is more important for our staffs, our doctors, our nurses, and all our infrastructures. So it is a good thing that COVID has given acceleration. It has made, it has forced our health givers to practice how to use the digital health care services. This is a good sign with respect to digitization of health services. But there are so many things, so many challenges, because in smart city parking, whether it is done by the physical guidance parking or by digital parking, it hardly matters, but it is not applicable in the case of services, healthcare services. When we meet a doctor face to face, that is entirely give different impression when we are meeting with technology, with digital health services. So there is a psychological effect also in healthcare services as compared to other services, with as he talked regarding in smart city like parking. So there are many challenges still prevailing, but certainly digital health services will accelerate and people will adopt it because they have practiced. That is my opinion.
Perfect, Dr. Hiraji. Thanks for highlighting the complexity in the health services. And let me request Mr. Raghavendra Prasad to give your opinion on this topic of digitization in health services after COVID-19 and before.
Thank
So,
you.
how have things evolved? Yeah.
Thank you, Dr. Ravi. And I would like to thank all of you for having me. I think the you can say the pandemic has been a defining moment for digital health in the country and the world. In fact, people call demonetization as a time when the Indian finance industry went from being mostly a offline, a very slow adopter of technology to some I think fintech is become a very big industry in the country, and financial services and access to financial services has greatly improved because of demonetization. People call the pandemic as the demonetization moment for digital health. In the sense, this pandemic has brought about changes across the board, and just to name a few, I think the first change it has brought about was telemedicine didn't have a legal framework in the country. Even now, actually, it lacks a legal framework as well as it should have. Compared to some of the legal framework in some of the more developed countries which have adopted telemedicine. But the pandemic forced the government and the government bodies to issue at least guidelines encouraging telemedicine, because they had no choice, and it had to happen. Also, it has forced to a certain extent all the government machinery to move fast in adopting technology. The showcase by the government telemedicine, and the PM himself announcing the National Digital Health Mission, I think is due to the fact that they were almost forced by the pandemic to move forward in the direction of digitization. One thing which I should specifically point out is the fact that the healthcare has been one of the industry. I've spent the last 10 years in digital health space, and healthcare has been one of the slowest adopter of technology in general, and that is because of first and foremost the doctors themselves not thinking of technology as a as something that is useful. I think from a consumer standpoint, always technology is consumers adopt very fast to technology, but somehow the doctors are very slow adopters of technology. And thanks to the pandemic, the only way they could still keep in touch with patients and actually earn a living was by adopting technology and adopting telemedicine and adopting more and more technology tools using which they can actually continue their practice. A key difference, I would say, is also the fact that governments are encouraging the use of technology. Just to elaborate a little bit more on that, I should introduce a little bit about what Project Step 1 does. Project Step 1 is a not-for-profit volunteer-led organization, which came into being when the pandemic was starting around March, because we knew that if there is going to be a widespread pandemic, then a lot of people will need access to doctors and access to telemedicine. And we came up with this idea that we will actually build a technology framework as well as a pool of volunteer doctors and medical professionals who will um, help all the people who are affected by COVID. And if you think about a situation before COVID, a project like this would have taken years to just establish, right? We were able to not only build the technology very quickly, I should say thanks to AWS and thanks to all the tools that are readily available to put together a system through which we were able to quickly put together a system thanks to all the technology that is available. And not only put together a system, but also we called for volunteers, and we have more than 7,000 doctors who are volunteering today with Step One. And adoption of this technology, we are currently live in about 16 states in the country. And every day we are handling roughly 15,000 consultations, teleconsultations, mostly by COVID positive patients. And we have done more than 2 million teleconsultations till date. And for an organization which is completely not profit, mostly survive, or I would say 100% surviving on volunteers, you cannot imagine something like this getting such widespread adoption in 16 states. 16. The pandemic has certainly, from a government standpoint, also opened up the channel for government to adopt and work with startups and work with digital solutions to problems. That I think is a great advantage that we have seen, that governments are increasingly. I think before COVID, no government institution would have been okay with hosting something in a public cloud. Now the use of public cloud services, which are far superior than any of the government cloud services like AWS or government is before, if you had to work with the government, you had to host your software in their own data centers, right? Which I think is we know from a technology point of view inferior, as well as from a red tape and a bureaucracy point of view much slower in getting things started. But that has also a huge change. So pretty much the entire ecosystem of healthcare and public health and government has changed due to the pandemic. I think the fast response that is needed, that was needed by the pandemic, has forced everyone in the ecosystem, as well as, I would say, citizens, right? So normal citizens have also changed, that they're okay to use digital channels, or they actually prefer to use digital channels now to reach out to healthcare. So it's a I would say a grand change that has happened due to the pandemic.
Thank you, Raghavendra, and I think it's a amazing success story. This Step One, that voluntary effort and scaling up so fast. So let me move on to our next speaker, and Mr. Safarullah, and I would ask him that what are the immediate steps to take in create a suitable environment for introduction of emerging digital technologies in healthcare. Like what steps as a or a government organization you think are needed to accelerate digital adoption in healthcare? Safarullah ji.
From my limited experience, I feel that the entire IT ecosystem in healthcare has more to do with change management. It is not more about technology, but it is about change management. It is how the doctors, the health practitioners will react to the application of technology, how the patients, as was said by a speaker earlier, would respond to a faceless or rather IT related teleconferencing instead of going and talking to a doctor and taking advice. So it has a lot to do from a change management perspective, and that is one of my learning also from the project, that once we target change management by training and upskilling the doctors, helping them by making friendly screens, and at the same time talking to patients and ensuring that they receive top notch quality treatment, then I feel a lot of things move forward. That is one. Second is about creating suitable IT architecture ecosystem. What I mean by that is for a small application like this e-health at the primary healthcare level, we had to provision 4 Mbps connectivity with redundancy. One we provisioned with leased line network, and the other through a wireless radio frequency network, just so that the redundancy is there. At the same time, the cost would be lesser. So this is one, the connectivity at the end, the last mile connectivity as we generally call. An extension of that is the data required and generated is extremely huge. Like for example, when we look at the packs in medical college, we have about 20-30 GB data generated every day, you know. And one is to store it and to transfer it to the data center and to store it permanently there. We had to have extension of national knowledge network 1 Gbps connectivity at medical colleges, because when we talk about medical colleges, we are talking about 5,000 6,000 patients a day. At a primary health center maybe 100 150 or whatever 200 depending on the population, so at each level setting this architecture at the last mile connectivity, at the data center, the cloud scalable platform, and storage as in SAN space. This is an IT ecosystem that we need to talk about. Second, the third one is about broad adoption. But I think adoption, we have had general increase, positive attitude towards adoption. Either COVID forced us, or we are now favorable towards that. Is anyone's guess. But we are open to expanding the reach. We are open to using of analytics software. But more importantly, the third point I wanted to talk about is about creating a data architecture, health data architecture, where we are able to use it. Now, COVID will maybe pass in the next few months, but then, as I said during my presentation, we have the public health data, right? Health, in my view, is not created in hospitals. Health is created before a man or woman reaches a hospital, right? So we have to start from the point that person, a kid is, a mother is pregnant or a kid is born, vaccinate him or her, and then go ahead. So there is a need for an integrated data architecture which needs to be created between public health system and yes, hospital management system, and various specialty programs, maybe a cancer initiative, maybe a tobacco control initiative, maybe a RCH initiative. So there are specialized programs which are launched by state government, central government at district level and all. So the 3 points, what I feel would be the critical factors would be: one, to take care of the change management. The second would be to create an IT architecture ecosystem. And the third and most important for long-term benefit is to create a data platform integrating at least to start with the health department and sister departments with public health, hospital management system, and specialty modules. So we are able to make informed policy adoption. What COVID has brought about is, yes, we have increased the usage more from the logistics stage, but I think unless these critical factors are addressed, we may be found wanting. So it is, I feel that we need to concentrate on these areas for long-term success in this field. Thank you.
Sure. Thank you, Safarullah ji. Let me move over to Aditi and ask her that the points which Safarullah ji has highlighted about change management and data architecture. So how are these issues being thought out by NHA, which is a key authority for healthcare IT implementation in the country? Aditi.
Thank you. So I feel that digitization and creating a digital health ecosystem primarily for the country, it is going to be a long journey. When you say that what are the immediate steps that have to be taken, I think we have to always take into account that we'll have to do it in a phased manner. Like I mentioned in the previous conversation, where I said that see, there are different softwares, different applications, different platforms, different agencies, different governments, different decision making authorities, different sorts of policies running around. So there is no convergence between all of them, and I think I resonate with what Mr. Mohammed was saying prior to that, that we really need to make sure that everything is converged. When he mentioned about how we need a singular architecture wherein we bring in everything together. So which is what is NHA is doing when we are saying we are introducing and bringing up the platforms for NDHM. And I think all of the problems or challenges just highlighted are being taken care of by the National Digital Health Mission. And when I say that we need to make sure that we do it in a planned manner, so now as on today, there are various organizations and various technologies that exist in abundance in our country. We don't know which ones are the best. So first, I feel we must identify the top few which we feel are the best and best fit to the kind of solution that we require, and then we identify the early adopters, because that is also, nobody would want to be the guinea pig in this situation. So we also need to make sure that we have early adopters. Once we have those early adopters, then we think about scaling up, and this is where our private cloud network comes into the picture, and we leverage all of that. We make sure that our scalability is agile and accelerated, and move away from the legacy of how government systems have been functioning. And yes, NHA does resonate with that feeling. One other thing that I would want to highlight is that yes, there has to be a behavioral change that has to come by, because today, till yesterday, even till today, I feel, even after telemedicine coming in and COVID coming in and hitting us in the face, the behavioral change in the doctors and the patients is what needs to be addressed. Because even today, even if you give a tablet to a doctor and you tell him that you need to make sure that you put up a diagnostic report and enter it yourself manually, the doctors here don't have that kind of time, and they will not be able. So there has to be an assisted mode sort of a feature that has to be made available for doctors. The second point that after convergence, the second thing I would like to highlight is standardization. When we talk about integrating with other platform, when we talk about integrating with other health schemes, we what challenges we have mostly been facing in the last few years is that there is no standardization of data, and there is no standardization of formats. So that is a challenge, is what we need to address. Lastly, interoperability. If the first to come, shake their hands together, interoperability is going to come as is. And just as an example, when I say interoperability, it means that say in Kerala there is a scheme that runs, and an e-card or a card has been handed out to a beneficiary. Tomorrow, under NDHM, if a person comes ahead and makes his health ID, both should be, the person should be able to use them interchangeably. So even if he gives his health ID, he should be able to take the benefits that are tagged to the health ID respective to Kerala as a state. So it's going to be a one shot platform wherein I, as a beneficiary, have 100 schemes or 100 benefits aligned with me, and just by a matter of providing my health ID, I should be able to take the benefits. So yeah, that's my point across around the question that you asked me.
Sure, Aditi. Thank you. And let me request Sridhar that you have implemented several smart city projects. So, asking of you that how effective has technological intervention been in making cities resilient in the face of COVID-19? Sridhar.
Yeah, definitely. It's very effective in terms of technology. It can do miracles. But in terms of the effectiveness, what we have seen is, one is the situational awareness at a city level, at a state level, at a country level, to understand what exactly is happening. Second is providing insights which will help to take the real-time decision making. Either it could be availability of healthcare resources, quarantine centers. Second, third is integration of different departments who are contributing to. So my pretty much response, everything is going to be how we fight about COVID, and how we should do in future if there is any natural or industrial disaster happens. How cities and state governments should fight it. So then, how do you seamlessly integrate and collaborate between a normal citizen, a field level worker, and the different governments together? And the challenge, which obviously we need to, your earlier question on, what challenges, what need to be fixed, is the data privacy loss. Especially healthcare data is very, very sensitive data. Once you have a very clear policy on when something like this pandemic happens, what kind of data privacy laws can have. For example, right, all over the country, safe city projects are implemented. Just in Hyderabad, we have around 20,000 cameras. If I can capture, even in fact, every shop establishment need to have a camera. If I can use that video stream, see the social distancing, whether they are following or not, see whether they are wearing the mask or not, what you can achieve is huge. But whether the data privacy laws allows, I mean, still the policies are not clear.
Yeah. So your point about data privacy is a critical, Sridhar, I think, and especially in the health context. And let me request opinion of Dr. Hiralal on what uh, we all need to do as health ecosystem, both in the government and the private sector, to enable more digitization of public health services.
Okay, thank you. Actually, so far we are talking about the approach top down. Top down system in governance in India is not that effective, which is expected. I am saying this based on my own experience. So, to get digitized the health care services, we need to change our approach from bottom up. Why I am saying this? This is my experience in different sectors, not in health sectors. As district magistrate in district Banda, in water, in malnutrition, I took the approach of bottom up. So what is idea in my mind based on my experience as district magistrate DC? There are different foundations. They are spending money on health in their CSR funds. If that fund and startup, there are so many bright startups, bright intelligent startups. If district administration, foundations helping through finance and other support, and startups, if three come together at district level, meaning thereby bottom up, then digitization scaling up will be faster as compared to the current scenario of top down. I am giving one example that is not my this statement, my this conclusion is based on my own experience. I was district magistrate in Banda. I took the help of Water Aid. Water Aid is a organization which is working globally in water area. District administration and water aid work together, and we got very astonishing result. Likewise in malnutrition, UNICEF and district administration came together and worked together, and we got very good results. So my suggestion is that if the foundations and startups and district administration come together and start working at district level, the digitization acceleration will be much more faster as compared to the top down approach right now. One thing. Second thing I would like to say, we are talking about the cure. We are talking about the cure. There is a sentence everybody knowing. Prevention is better than cure. In the since last 5 6 years, I never talk about the cure. My focus is prevention. So digitization should also rush into the field of prevention. Why we should get ill, then we get cured. Nobody wants to get ill. So we should digitize or we should provide digital services to prevent the illness. That is my another field of concern, and which I am pursuing. I talk less about in even in districts. I used to focus less on the cure side, and I used to focus and divert my energy on prevention side, so that we need not require hospital, we need not require doctors, because we will not get ill. So in digital healthcare services, my request that we should change our focus from cure to prevention. In the sentence, prevention is better than cure, and I am following it, and I am getting good results. So these
Great.
are my 2 points.
Excellent point, Dr. Hiraji. And I have got a message from two speakers that they have to leave at 3:30. So let me request, Hiraji, you have mentioned about involvement of voluntary agencies. And we have an NGO here, a non-government organization, Raghavendra. So Raghavendra, your last comment, I think, we will end with you about that. How can people outside the government, NGOs and voluntary organizations collaborate with the government agencies to digitize public health care? Yeah, Raghavendra.
Sure. I think um, I feel the in case of Project Step One, in most cases the government have collaborated because there was a real scarcity of resources. Right? The government really wanted to get a system through which they can scale the number of healthcare providers and the number of people who can support them, and there was no way to do that without a technology platform as well as a group of volunteers like what is there with Project Step One. I think this should become a model going forward. The government typically, this is something that I've seen with the bureaucracy. The bureaucracy typically wants everything to be done within the government by the government, and often that becomes a bottleneck. And often that, especially for public health, it is almost impossible today. It's almost impossible for the government to actually deliver healthcare to each and every Indian. The private sector, as well as the impact sector or the development sector, have to very much be involved, and there has to be more and more models evolved to get best in class organizations, whether it is private or government, or for that matter NGOs together. The other key thing, I think, for the digitization aspect to succeed is the laws itself. I think Sridhar also pointed out to that. I think the legal framework in the country right now is pretty poor, especially for a much wider adoption of telemedicine and much wider adoption of digitization in general in healthcare. And so it is, on one hand, the government talks a lot and talks about digitization and pushing it, but on the other hand, the laws and the legal framework that is required is just not there, which deters all the participants from actively participating and pushing more in the digitization part. I think these two things, if they're addressed, then we would have a much faster and wider adoption.
Thanks, Raghavendra. And since we are running short of time, and several speakers have to leave, so we will conclude this session here. And I thank each of you for joining us and sparing time for this event, Digital Health Conclave. And thank you. And namaste to each of you. Thank you so much. We'll close it here.
Thank you.
Thank you.
Thank you.
Thank you. It was
Thank
our
you.
pleasure. Thank you.
Thank you.
गुप्ता जी इन लोगों को यूपी में लाइए, हम लोग इनको यूपी में जो है काम करते हैं मिलके यूपी में। आइए राघवेंद्र जी हमारे साथ काम करिए।
ठीक है सर, हम तो, हाँ, हम तो किसी के साथ भी काम करने के लिए तैयार है। तो आई विल कॉन्टेक्ट यू डॉक्टर हीरा आफ्टर द session, and I'll also connect with you, Safirullah sir. Thank you, Gupta ji. Well conducted.
Thank you so much,
Thank you.
Raghavendra ji, and thank you, Hira ji. Namaskar.
थैंक यू गुप्ता जी, थैंक यू, नमस्कार।